Thank you, Cody. Thank you very much for inviting me here, and also thank you to the organizing committee and the SICOT and the Thailand Orthopedic Association. I was working with lumbar fusions for many years, and the two questions I like to try to answer in this talk is, does it work at all? Number one, and secondly, does the type of fusion matter? Thirdly, I will also discuss a little bit about disc prosthesis. Surprisingly, the fundamental evidence for whether fusion works or not is quite limited. The first randomized study showing the efficiency of lumbar fusion was our presentations of adult isthmic spondylo-listhesis in 2000, where we show that in adult isthmic spondylo-listhesis at 2 years follow-up, fusion had an excellent to good rate of 73% compared with exercise at 23%. We followed these patients for 10 years, and the results for the fusion group were still the same, with 76% good or excellent compared with exercise 50%, showing that fusion did seem to work. The second RCT showing efficiency of lumbar fusion was the Swedish Lumbar Spine Study from 2001. This is 300 patients randomized from 13 different Swedish centers, again showing that fusion was better than physiotherapy at 2 years. The difference was not that great, but statistically significant, and something like 15-20 Oswester disability points. However, the picture is not that crystal clear. There are two randomized studies, one from Norway and one from England, showing that no difference between the fusion group and the conservative group. In the Norwegian study, the control group was a cognitive therapy group, and also the series of patients was quite limited. In the England study, the inclusion criteria was quite strange. Actually, patients where the surgeon thought that the surgery would benefit the patients were excluded, and maybe you should not surprised that you have a poor result. Thinking about the cognitive therapy in the Norwegian group being similar to the fusion group stimulated us in Sweden, and also the group in Aarhus from Professor Binger's group, showing that a cognitive type of rehabilitation seemed to improve postoperative the results. We started a study on early rehabilitation following lumbar fusion using cognitive as well as physical therapy, postoperative intervention, and we found out that this was improving the results. These are the results presented at the Eurospine last week in Poland, showing the Osability Disability Index clearly better in the group where fusion was combined with cognitive type of therapy after surgery. So what about the long-term effects of fusion? The problem of possible adjacent segment degenerative disorder has long time been discussed, but good EBM type of data has been scarce. We follow our spondylolisthesis for average 13 years, and this is a typical picture of a spondylolisthesis operated on 15 years earlier, where you can see the quite nice disc pre-op here, and 15 years later you can see a slight but still quite clear deterioration of disc height, and particularly the posterior disc height was in most cases reduced at long-term follow-up. In the controls, surprisingly, there was very little disc degeneration at 15 years later. Actually, we could not find very much at all. We used the UCLA grading scale, and actually in the exercise groups, most of the patients were completely normal, whereas in the fusion group, there was quite a bit of degeneration. Also, we find out that the outcome with the adjacent segment problem was less good in patients with ASD compared with patients without ASD. The percentage of patients much better is much less in the ASD group. So I think we pretty well show that ASD does exist. This has been a controversy for many years. However, severe adjacent segment disorder is uncommon only in 5% of our patients. That means that 95% of fusion patients do not have it 13 years after fusion. It does seem to have a slight negative effect, although not that, great. So the first question, does fusion work? I think the question is yes. The mid and long-term effect is a modest improvement compared to conservative therapy or natural history, and this is true for degenerative disc disease in general and also for adult isthmic spondylo-listhesis. I think the Norwegian and English studies are flawed for different reasons, as I discussed. Next question, does type of fusion matter? In our spondylo-listhesis study, we looked on posterior lateral fusion with or without instrumentation, and we could find no significant difference in pain, disability rating index, oswestry, global assessment, SF36, or adjacent segment disorders at 2 years or 13 years follow-up. So in posterior lateral fusion, it does not seem like instrumentation or not matters. This is also reported by Cody Binger's group from Denmark. The same was true in the Swedish Lumbar Spine Study, where we had 3 different types of surgery: posterior lateral fusion with and without fixation, and also 360-degree fusion, ALIFs or PLIFs. And we have exactly the same outcome in all 3 groups. However, subgroup analysis were actually not possible because of the subgroups on 360 were too small, I think, for a good conclusion on that issue. There are several theoretical advantages with interbody fusion. As we all know, the load of the spine is 80% is anterior. The disc is probably the origin of pain in many patients. With interbody fusion, you do get an increased fusion rate. You do have the potential of an increased lordosis, and you do get foraminal decompression directly or indirectly. So a little bit discouraged by the no benefit of instrumentation in the adult isthmic spondylo-listhesis series, we started a new series where we compared PLIF versus posterior lateral fusions. And this is a prospective comparative study. It's not a randomized study, but the inclusion criteria were exactly the same for these patients as for the posterior lateral fusions. So we did 164 PLIF patients with a follow-up rate at 2 years of 98%, typical for a Swedish study, I would say. Just an example, a 51-year-old female, isthmic spondylo, instrumented with a PLIF and a PLF, L5S1, and you can see the increase in disc height, and you can see the bone packed in between the cages here and here, carbon fiber cages, radiolucent, bone here, 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 and also posterior lateral in this series. These were the results for pain at 2 years. As you can see, absolutely no difference between the 2 types of surgery. This is the global assessment. The number of patients much better, actually slightly higher in the PLF group. Difference not significant. Same outcome. Again, discouraging results for whether type of surgery matters for this type of disorder. So what about TLIF instead of PLIFs? TLIF has a couple of characters which is better than the PLIF. It's less canal violation. The TLIF is done here, the PLIF is done here, and the PLIF is done also bilaterally. Minimal or no nerve retraction, less bleeding of the PLIF. A number of retrospective studies stimulated us to do something prospective on TLIFs. We use the standard transforaminal approach. For implants, we use the porous tantalum, trabecular metal type of implant, and with the cage positioned like that. Standard approach with removal of the joint. I did some dog research showing that you do get bone ingrowth into the bone. This is bone, this is the tantalum, and this is bone growing, and this is dogs at 6 weeks. So this was the study presented last week in Warsaw, where we compared transforaminal lumbar interbody fusion versus posterior lateral fusions without fixation in degenerative disc disease and post-discectomy syndrome. We had 135 patients. They were randomized to PLIF or TLIF, 2-year follow-up, 97%. Typical case, degenerative disc disease, L5S1, TLIF like this, lordotic segment with improved disc height. And this is the disability rating index at 2 years, significantly also clinically significant difference compared to the PLF with 11-point, 10-point Oswestry disability index difference too. The most impressive figure, although it were the global assessment, was surprisingly high for the TLIF group, where the excellent or good actually together were 91% of the patients, a figure on patient satisfaction that is more or less unprecedented in spinal fusion literature. Even in retrospective studies, they rarely come to this high percentage. It was compared to the much lower percentages for posterior lateral fusions with more like standard 70% satisfaction rate. With a significant difference between the groups. So we had to conclude that the results certainly were significantly better with TLIF compared to PLF, and also that the overall percentage was so high, was very high, also compared to previous literature. What about ALIF or 360? Standalone ALIFs with only interbody devices or bone has a poor literature support, and very few people use it today. So ALIFs are often combined with posterior fixations, and the interbody thing is usually performed with anterior tricortical autografts, femur rings, all cages, and posterior fixation. Again, Danish group under Cody did a nice prospective randomized studies comparing ALIF and posterior lateral fusion and fixation, and show that this was very much better than posterior lateral fusion and fixation. This is a recent study from 2008, a prize-winning study at the ISLs. So if you summary the situation, the evidence-based medicine situation on interbody fusion, Swedish Lumbar Spine Study did not show any improvement with interbody fusion, neither did our spondylo-listhesis studies. However, the Danish study on DDD and our study on DDD showed very consistent results with an improved outcome for interbody fusions. So this study applies to spondylolisthesis. It may be different, and this study actually was too low power to make any strong conclusions on the interbody issue. A few words on disc prosthesis. This is in fact the very first disc prosthesis, also from Sweden, of course, in Gothenburg. This is the SKF balls positioned in President Kennedy in 1960-something. And actually this has been followed up in the Canadian studies for something like 20 years, and with surprisingly good results. The procedures was, however, abandoned for different reasons than scientific ones. New prostheses have come along, and the rationale is, of course, to keep the patient moving. And there are very many types of disc prosthesis today. Metal on polyethylene, metal on metal, different designs, and it's about the situation the same as in hip arthroplasty with hundreds of different prostheses around. This is a patient of mine done a couple of years ago with a bad L5 S disc. Now the patient was improved at 6 months, but he was far from excellent. So what is the evidence-based medicine situation for disc prosthesis? A number of, or actually 3 randomized controlled trials has been published the last 2 years, all 3 of them American. And one of them had a 5-year follow-up, and that was the CHARITE prosthesis, which was tested against PLIF with BAK, which is a standalone technique, which we know is a poor technique, and actually no statistical differences were found between the groups. But the authors concluded that this supports the use of the CHARITE prosthesis. I'm not sure if I would draw that conclusion comparing the artificial disc with a inferior fusion technique, but still that was taken for supporting its use in this study. Another study was on FlexiCore, comparing with circumferential fusion with a 2-year follow-up, and with the FlexiCore was at least as good as the circumferential fusion. And the third one is a 2-year follow-up comparing ProDisc with circumferential fusion again, and showing that actually the outcome of the ProDisc was better than the circumferential fusion. Hybrid things have been used, but today they are quite popular today, but with a fusion at the bottom and then a disc prosthesis on top. But there is no data available for this type of construct. To summarize the evidence-based medicine situation on disc prosthesis, we have to conclude that equivalence or superiority to natural history or physiotherapy for disc prosthesis is not demonstrated. All studies have decided to compare it with fusion. Of course, you would like to have a study comparing to conservative treatment. There is, as far as I know, no such study done or either underway. The main argument for disc prosthesis is the prevention of adjacent segment disorder. This is not yet demonstrated. It probably takes something like 10 years follow-up to do this, and we have no data on that issue as of yet. We have no long-term results. 5 years is the longest. We do have some long-term results, but it's not on a randomized fashion. It's on the old CHARITE prosthesis. Most of them went on to spontaneous fusion. But that was an old design, and probably we should not draw any conclusions on the results of the old CHARITE type. Because there is, in fact, the short and mid-term results seems to be at least similar, or in a couple of studies, better for the disc prosthesis than for fusion. That's the last, I think, slide on the most controversial area in spine surgery, the low back pain, the degenerative disc disease area. A recent systematic Cochrane review stating that the definite proof of treatment efficacy for both fusion and non-surgical treatment of symptomatic lumbar degenerative disease remain unclear. Maybe it's a too strong statement. I do think there are some good studies around supporting fusion, and also by that supporting the use of disc arthroplasty in selected patients, although the results are not that dramatically good as we all know. So, winding up with a couple of conclusions, I think there is a weak recommendation of fusions for degenerative disc disease. I think today that the weight of evidence supports the use of interbody fusions, and maybe we should exchanged the old gold standard posterior lateral fusion to the interbody fusion. This is something that can be discussed, but I think the studies today are so strong that we cannot avoid to posting this statement here with a little question mark in behind. The simple posterior fusion certainly is a viable option still today, with a number of studies showing similar outcomes with it as compared to more expensive and also procedures with more complications. The more sophisticated procedure, the more complication. It is as simple as that, as we all know. And also conclude that the disc prosthesis still is an experimental procedure. Finally, I want to thank you for your listening to this little presentation on the EBM situation, and also, maybe most importantly, I'd like to welcome you to next SICOT meeting, which is in my hometown, Gothenburg, Sweden, and it's a combined meeting between the Swedish Orthopedic Federation and the SICOT, and it will be on August 30 in Göteborg, Sweden, and well,
thank you. We will thank you, Rune. Thank you, and
you're
thank
coming,
you.
Cody?
Yeah.
Thank you.
Okay, but thank you.